Recording in progress.
Good evening, doctors. We will start in a minute. Thank you. Good evening, doctors. Welcome. I'll be your host for tonight's webinar. I am Nancy Reyes from Corporate PSQM Senior Associate. Tonight's webinar is entitled Renal Denervation, the Next Treatment for Resistant Hypertension. Welcome to our webinar. To avoid distractions during the lecture, kindly follow these instructions. Keep your mic on mute. Turn off your video camera. If you have questions, send to us by typing in the chat box. We will answer your questions during the Q&A session. Please do not forget to fill up the evaluation and post-test at the end of the lecture. This serves as your attendance. Thank you, and let's enjoy the knowledge sharing today. To start with, let me introduce our moderator. He graduated Bachelor of Science in Human Biology at the De La Salle University, Dasmariñas, graduated Doctor of Medicine at De La Salle Health Sciences Institute. He is currently Public Relation Officer at Santa Rosa Medical Society and Assistant Director of Ancillary at Qualimed Hospital, Santa Rosa. Please all welcome Dr. Aaron Christian Earl I. Villoso.
Good evening, dear doctors, and welcome to another webinar series under corporate. So we are honored this evening to be headed by our lecturer for tonight for the very interesting topic of renal denervation. So without further ado, let me introduce our speaker for tonight. So our speaker for tonight had his Bachelor of Science in Biology at Ateneo de Manila University and had his Doctor of Medicine at UST Faculty of Medicine and Surgery and had his residency training in internal medicine at Cardinal Santos Medical Center and is also a fellow of the Philippine College of Physicians, Philippine College of Cardiology, and Philippine Society of Cardiovascular Catheterization and Intervention, Asia Pacific Society of Interventional Cardiology, and is currently the chairman of the Committee on Coronary Imaging and Physiology, past president of the Philippine Society of Cardiovascular Catheterization and Intervention Incorporated, and also the immediate past director of the St. Luke's Medical Center BGC Cath Lab, and is also an active consultant of the same institution. So without further ado, let's all welcome Dr. Jose Nicolas M. Cruz.
Thank you very much for that kind introduction, Dr. Villoso. Am I audible?
Yes, sir.
Okay, great. Okay. So I was assigned to discuss the topic on, let me share my screen first. My slide can be seen, Dr. Villoso.
Yes, po, sir.
Okay, great. Okay. So I retitled my presentation tonight as renal denervation, the third option in the treatment of hypertension. We usually think of resistant hypertension as something that is more than 180 over 120. That is actually a hypertensive crisis. So just to let you know that any form of uncontrolled hypertension is actually called resistant hypertension. So just to give you an outline of what we will be discussing tonight, it is to briefly discuss the global challenge of hypertension control. And I'm planning to present the history of renal denervation as a treatment for hypertension. And also briefly present how radiofrequency renal denervation is performed, and discuss with you the most recent spiral hypertension clinical trials and also the global registry on this, and share some current recommendations and consensus statements regarding renal denervation as an option for treating hypertension. Okay, so what are the challenges that we face in controlling hypertension globally? Well, we are all aware that there is a hypertension crisis. A lot of people are hypertensive. A good proportion of patients are, I'm sure all of you would see a hypertensive patient at least once a day. And the incidence of hypertension in the world is globally high. However, the control rates are low, and hypertension, as we all know, leads to end organ damage and death, primarily renal failure, congestive heart failure, strokes, and other vascular complications. And something that is happening, that is real in our world, is that there is poor medication adherence for several reasons. Maybe the patients don't want to take medicines, maybe the patients cannot afford to take medicines, or maybe they are not educated as to how serious the condition of having uncontrolled hypertension is. Now, this is okay, I'm sorry. Okay. Here we see that less than 25% of our patients are, only 25% of our patients are controlled worldwide. And among men, it's about only 18% are controlled. And among women, only about a quarter of these patients have blood pressure that are controlled within our target. Let me just fix this. Just give me something. I just have a little bit of technical issue from my end here. There, got it. Aaron, can you see my screen?
Yes po, sir.
Okay, because I'm seeing other things here, and everybody that tries to enter, I also see. So how do I remove that? Okay. Anyway. We were discussing earlier that adherence to antihypertensive medications worldwide is poor, and only about 17% of patients, and actually 44% of patients are not taking their antihypertensive medications, and patients who are prescribed so many medications, actually less than 1/5 of these patients are actually taking their medicines. Now, if a patient is put on 2 to 3 medications, this means that there is like 200% or twice the chance that these patients will not be taking medicines. And patients taking 5 medications, about half of these patients will not be taking their medications. And majority of patients prescribed more than 6 medications are actually non-adherent. So is it time to consider something on top of lifestyle, on top of medications that will help us in controlling our patient's blood pressure? So here now comes in the idea of a device-based hypertension therapy. Okay, and we know that the kidneys and the brain communicate, and other organs as well, communicate in such a way that it controls blood pressure very well. But also, if you have some form of disease, then as we all know, disease always would bring some disruption in normal mechanisms, and the communication between the kidneys and the brain become abnormal. And this is when a device-based hypertension therapy comes in. This is actually an old concept, way back in the 1930s, when they would do sympathectomy to be able to control blood pressure well. However, sympathectomy may lead to a lot of, or actually led to a lot of adverse reactions, particularly postural hypotension, and of course, erectile dysfunction among men. And this is the reason why it was abandoned, because patients would have good blood pressure control, and yet when they would stand up, their blood pressure would fall down. So it took about quite a number of years before people started looking again into the role of denerving the nerves coming from the kidneys communicating with the brain. And so they realized also that this kind of communication affects myocardial function. This type of communication affects vascular tone, and that is the reason why complications may happen if there is disease that ensues. So there were actually 3 trials called Simplicity, because they said that the catheter was simple to use. The Simplicity HTN1 trial, Simplicity HTN2 trial, and the Simplicity HTN3 trial. The Simplicity HTN1 trial was the first in man and the proof of concept. They tried to find out whether denerving or denervating the kidneys would result to lower blood pressure. So first in man proof of concept, and they found out that it was positive. The Simplicity 2 trial was a randomized clinical trial, and they found out that it really works. Okay, so going back to Simplicity HT1, it's the first generation single electrode catheter that was used, and it appeared safe, associated with significant reduction in office blood pressure, both at 6 and 12 months, and even persisting up to 3 years. Again, as I mentioned earlier, it's a proof of concept first in man registry, and they achieved very impressive 32/14 mm blood pressure reduction from baseline. So this is a representation of the results of the Simplicity HTN1 trial, done more than 10 years ago. The primary investigators were Australians, and actually that was the time that I got interested in this. Okay, this is a graph again of how effective the device was. So this is a proof of concept that the device really works. Simplicity HTN2 is a prospective randomized controlled clinical trial. Again, very impressive. 33 over 11 millimeter drop in blood pressure. But kind of too impressive for some people. How can a device mediated blood pressure control lead to such significant improvement better than medications? So impressive. And that is the reason why they said, okay, let's do another trial. This time, according to the FDA requirements. And you know that the FDA has very stringent standards. So what they proposed was to do a sham procedure. The patients would go to the cath lab, undergo a procedure. Patients were not told whether they really had the actual denervation. They were put on sedation, and that is the reason why they would not remember whether they actually had it or not. And the staff were not even, the cath lab staff were not even informed who had the actual procedure on who did not. So this was a double blind and a sham versus the actual trial. A sham means akala mo lang, you think it happened, but it did not happen. And the actual procedure was, of course, the actual procedure. However, this was reported in 2014 and quite disappointing at a certain point, because apparently there was no significant difference between blood pressure reduction in the sham controlled versus those that actually had the procedure. They both lowered down blood pressure, but probably the psychological effect of the sham procedure led to lowering down of blood pressure as well. So it was proven to be safe. It was proven actually to be effective, but the sham procedure was likewise effective. So of course, bad news. So it spread all throughout the world. Renal denervation failed to meet the efficacy endpoints compared with a sham procedure. However, one thing was clear: the procedure was safe, and there might have been some technical problems that led to no difference between sham, between placebo, and the actual procedure. So, what were the possible mistakes that happened? Because Simplicity 1 was positive, Simplicity 2 was positive, yet Simplicity 3, using the sham procedure compared to the sham procedure, turned out to be negative. So, what could have gone wrong? Possible limitations of the Simplicity HTN3 trial? Probably the study design was flawed. Maybe they targeted the wrong population. Just as a reminder, for those of you who are aware or are familiar with the Simplicity HTN3 trial, this was done exclusively in the United States, while the Simplicity 1 and Simplicity 2 trials were done in Australia and in Europe. Probably there was an issue of operator expertise, because this was exclusively done in the United States where there was no previous experience by the operators. Maybe we were targeting the wrong areas for renal nerve distribution. And maybe the design of the catheter was it's not perfect. It was flawed. It was effective, but not perfect. And maybe the ablation protocol that was used was not correct. So what happened was to review the concept of renal nerve distribution. And then what was discovered was that renal nerves were actually closer to the blood vessel walls in the distal portion. And in the Simplicity HTN3 trial, what they were trying to ablate was the proximal nerves. There were more nerves in the proximal portion of the renal artery. However, they are a bit distant from the site of ablation, while distal nerves were more scarce, but actually nearer, as you can see in this representation. So this is a pathologic representation of this. You see more nerves actually in the proximal portion. However, they are closer in the branches of the renal arteries. So there was a change in concept, and they tried this on pigs, and this is called the IBY preclinical trial. I means you only denervate the main vessel, a straight line. That's why it's called the I. V is you denervate only the branches, the V, the bifurcation. And Y means you denervate both the I, which is the main branch, and the bifurcation or the distal branches. And they found out that this seemed to be effective, at least in the porcine model among pigs. They also revised the design of the catheter. It used to be a flex catheter, which I was able to use way back 2013 also. But this required more time and more precision in trying to rotate the catheter. There was only a single electrode catheter, and you had to press the electrode to deliver single ablation. While the Simplicity spiral catheter, the new one, is actually coiled. It can deliver simultaneous energy within 60 seconds, and you can ablate four sites in one ablation. So it was easier to use. It had more contact with the wall of the blood vessel, and also it was shorter. It was shorter in terms of procedure time. So from flex to spiral. So this is a representation of how we used to do it using the old Simplicity flex. You would notice that we would only ablate the proximal renal artery and avoid the smaller branches. With the new concept that we started after 2014, we would ablate the letter I, the proximal portion, and include also the branches, which would be the V part of the renal artery. So this was an IVY ablation. So this is a representation. And just to, again, just to give you a short movie. Designed for ease of use, the catheter is compatible with most interventional catheter designs, similar to but much less complex than those used in generator employs a responsive algorithm based on real-time temperature and impedance feedback to optimize procedure efficiency. Renal denervation catheters are then vertically grouped to one of the more arteries and then guided to the renal artery, usually the six-stretch catheter, similar again, but shorter than the one in the so-called. Once it is positioned at the entire treatment rotation, the guidewire is instructed to deploy the renal denervation catheter, which naturally responds to the rotation. Cylindrical shape along the spiral electrode path outward forward part of the rotation. This natural coil provides a consistent opposition. Renal anatomy varies significantly in all patients. The versatile design spiral catheter allows us to treat all patients. With this system, the operator is able to use that each electrode avoiding unintended application of damage to non-target organ. Same catheter is easily repositioned contralaterally. So it may sound too technical to you, but actually it's pretty simple. It's much easier to do renal denervation compared to doing coronary angioplasty. Now, let me share with you the spiral HTN clinical program. Again, we were disappointed with the results of the Simplicity HTN3 trial. So there's a new set of trials that were spearheaded because the company believed, and all other believers of device-based renal device-based hypertension control programs believe that it works. There was something wrong with the HTN3 protocol, perhaps. So what they did now was to do what they call an off-med trial. These were patients who were hypertensive, but not on medications. They were not put on medications for about 3 months, poorly controlled blood pressure, and then these patients underwent, again, sham control. They did not undergo the actual procedure. And half of these patients underwent the true procedure, which is renal denervation. And these patients were followed up. The population was pretty well matched. And the not so impressive at first, but again, this is a proof of concept that it works, because for both systolic blood pressure and diastolic blood pressure, again, both office blood pressure and ambulatory blood pressure, there was a significant reduction in the patients who underwent the actual procedure compared to those patients who did not undergo the procedure. Okay, so this is clear. It works, maybe not as impressive on the first determination, but it is a proof of concept that the system works. This is also something that is significant because with medications, the tendency is to have some differences in cycles. You may have elevation in blood pressure when your medicine is starting to wear off, or sometimes in the early morning, and then some initial drop in blood pressure after taking the medicine. The beauty of renal denervation is that it is always on. Because there's no pill to take, the effect is there for 24 hours. And we see this in the renal denervation group compared to baseline, and in the sham control group, where there is no always on effect of BP control. So the nighttime and early morning period is usually associated with increased risk for stroke and cardiovascular events. And this is one benefit of undergoing renal denervation, because it's always on. So what were the conclusions of the hypertension off-med trial? These patients were not on medications. In uncontrolled hypertensive patients, in the absence of medication at 3 months, both 24-hour ambulatory BP monitoring and office blood pressure showed clinically meaningful BP reduction at 3 months. It was always on. It was independent of patient adherence to medication, and there was consistent BP reduction during nighttime when actually your cardiovascular risk is highest. And what is very important, again, is that just like in Simplicity HTN-3, there were no major device or procedure-related safety events through the 3 months that the off-med pivotal trial was done. Now, how about in patients who are already taking medications, but still with poor BP control? Not necessarily resistant, but still with poor BP control. So again, similar design, randomized sham control trials, and these patients were followed up, though both the ones who underwent renal denervation and the ones who had the placebo. And this was reported by Felix Mahfoud just last year during the American College of Cardiology conference. And he reported a significant drop in patients who underwent renal denervation already on medications compared to those who had the sham procedure, even if they were already on medications. And this persisted up to 36 months, or up to 3 years at least, in the report last year. Now, this was consistent both for 24-hour systolic blood pressure, both for morning systolic blood pressure, daytime systolic blood pressure, nighttime systolic blood pressure, and even the office systolic blood pressure, because it was an always-on treatment for poorly controlled blood pressure. So this was the 24-hour BP control at baseline and at 36 months. So significant reduction. And the patients who were able to obtain less than 140 millimeter mercury during the 24-hour systolic blood pressure was actually 83% in denervation and less than 50% only in the sham control at 36 months. Safety, again, is actually not an issue, which is the biggest issue as far as I'm concerned. Something that is safe is always beneficial. So what are the implications of all the available evidences that we have from the spiral HTN on-med trial? Significant reductions in nighttime and early morning, similar to the off-med trial, which could translate actually into reductions in cardiovascular events, including stroke and heart failure and probably renal failure. The sustained nature of the 24-hour BP reduction with renal denervation might be actually superior to treatments with drugs, which are often associated with non-adherence. And the data support the favorable long-term safety profile of catheter-based renal denervation. Renal denervation, based on the results of the spiral HTN on-med trial, provides an adjunctive treatment modality besides lifestyle modification and medications in patients with uncontrolled blood pressure. So both of those, the off-med and the on-med trials were randomized trial. How about in the real world? In the real world experience, it is registered in the Global Simplicity Registry, or GSR, which is the largest data set with multiple subgroups. This is real world again. There is now evidence of durability, meaning it lasts long, and safety, which have been established in all the 3 trials, including the quite frustrating HTN3 trial. And this again is in the real world setting. So it is the largest registry. As I've said, we are targeting 3,000 consecutive patients, at least 5,000 rather. At least 3,000 patients have already been reported. And there is significant BP reduction sustained all throughout up to 3 years, both for office systolic blood pressure and 24-hour ambulatory blood pressure. The change in blood pressure, or the drop in blood pressure, was consistent whether the patient had resistant hypertension, type 2 diabetes, or even in patients with chronic kidney disease. Same thing also for those with stable ischemic heart disease, for the elderly patients, and for patients with atrial fibrillation. Same thing was seen, that was the office blood pressure. Same thing was seen also for patients who underwent ambulatory BP monitoring for resistant hypertension, type 2 diabetes, CKD, ischemic heart disease, elderly patients, and atrial fibrillation patients. Now, whatever medications you were the patients were taking, there was also consistent, or whatever number of medications they were taking, there was consistent improvement in blood pressure in those patients who underwent renal denervation compared to the sham procedure. So this is pretty important because there was a 3-fold increase in the percent of patients who were able to reach a BP of less than 140 over 3 years. And this, although not so significant, this was with the same amount of medicines, or perhaps numerically lower number of medicines with renal denervation alone. So again, this is office blood pressure and ABPM for both resistant hypertension. The first one was the non-resistant. For resistant blood hypertensive patients, 55%, more than the previous one. 55% of patients with resistant hypertension actually achieved a blood pressure of less than 150 at 3 years, again, with a lower number of medications. And this was true also even for patients who had lower or reduced eGFR, or chronic kidney disease patients. Okay. Now, this is important. Again, safety profile is very good, so no issue about safety. But what's important for us is to realize that the current recommendations now are actually more strict. The 2017 American College of Cardiology guidelines and even the 2022 European Society of Cardiology guidelines are more strict now with BP control, because they have realized that even just a 10 or even 5 millimeter reduction in blood pressure and 10 millimeter reduction in blood pressure actually leads to about 20% reduction in cardiovascular events. So anything that would lower down blood pressure will significantly lower down adverse effects like heart failure, kidney failure, and strokes, atrial fibrillation, including in patients who have poorly controlled blood pressure. So for most of you, I hope you are aware that what we now consider as normal BP is 120 over 80. And anything that is more than 120 is already considered elevated. Stage 1 hypertension now is at 130 to 139, and anything above 140 systolic is already considered stage 2. For diastolic, the target or the normal BP level is less than 80. And any figure from 80 to 89 is already considered stage 1. And more than 90 diastolic blood pressure is already considered stage 2 hypertension. So the targets are actually more strict now, because whatever clinical condition the patient may have, whether there is clinical cardiovascular disease, whether the patient is old, patients with specific comorbidities like diabetes, CKD, heart failure, etc. Look at this in the box. The target or the BP goal is all less than 130 systolic blood pressure and 80 diastolic blood pressure. This is a target that is quite difficult to achieve for most of our patients. And the problem is, on top of lifestyle and medications, we still have evidence that blood pressure can still not be controlled up down to this level. So, what are the position papers that were released in 2021? There are two big ones from two big groups, the European Society of Hypertension. We can start with this first. This was a consensus paper that was released in 2021. And their consensus is that renal denervation represents an evidence-based option to treat hypertension in addition to lifestyle change and BP lowering drugs. Again, it is emphasized that there should be lifestyle change, and use of BP lowering drugs have been shown with enough evidence that it can lower down the incidence of adverse effects. Renal denervation expands our therapeutic options to effectively reduce elevated blood pressure and achieve BP targets, and it is considered a safe endovascular procedure with no significant short-term or long-term adverse effects based on data available at least up to 3 years. From the same paper, it says renal denervation is alternative or additive, should not be a competition to the current treatment strategy, and there is now emphasis on patients' perspective and preference and the stage of hypertension disease, which should lead to an individualized treatment strategy. There should always be a shared decision-making between the patient and the doctor. And of course, the patient also should have managed expectations that renal denervation is not an alternative to lifestyle and medications, but it is additive and not competitive rather. Now, the Society of Coronary Angiography and Intervention in the United States and the National Kidney Foundation in the United States also issued their consensus statements in 2021. And these are the statements: that efficacy for uncontrolled hypertension has been consistently demonstrated in renal denervation sham-controlled randomized trials in the presence or absence of medications. And current evidence suggests that there is a constant reduction in blood pressure over day and night, what we call the always-on effect, that is different from pharmacokinetic profiles and dosing regimens with medications and patient non-adherence. And both randomized trials, this is the off-med and the on-med trials, and the Global Simplicity Registry support the early and late-term safety of renal denervation. The American consensus also says that renal denervation is associated not only with improvements in blood pressure, but also reduction in medication number and or dose. And although registry data suggests long-term durability, longer-term surveillance of existing trials and additional studies may actually help us decide regarding the durability and impact on clinical outcomes. Definitely, this is something new, so we need clinically useful and reliable predictors, responsiveness that need to be identified. Now, you will notice here that there is emphasis for both the European recommendation or consensus paper and the American consensus paper that there should be shared decision-making. That it is not just the doctor who will decide what to do with controlling blood pressure. The patient should also be given options. And the options are, of course, lifestyle change, medications, and renal denervation. Now, more and more guidelines are coming up. Actually, there were 2 new guidelines from Taiwan and the Malaysian Society of Hypertension that came out last year, emphasizing the role of renal denervation as a third option in the treatment of hypertension. I just present to you a few cases that we did in St. Luke's Medical Center. The, the first case that I will present is a 52-year-old male who has been hypertensive for more than 10 years. He has obstructive sleep apnea. He was compliant with his CPAP. However, his blood pressure was still poorly controlled despite taking calcium channel blockers, angiotensin receptor blockers, and a diuretic. The target now is less than 130 over 80, and he is pretty young. So we wanted him to reach this level, but he refuses to take more medications. So we offered this to him because he was anxious about adverse reactions to adding more medications. And we did first, of course, this is how the procedure is done. You do an aortogram just to identify how many renal arteries there are. Because some patients have more than two renal arteries, one on the left and one on the right, plus some accessory renal arteries. So an aortogram is done to identify how many renal arteries are there. Selective angiogram of the right and left renal arteries, or if there are accessory renal arteries, you also do selective angiograms on this. You position your catheter into the distal vessels. You try to avoid the parenchyma. You would not want to ablate the renal parenchyma. Of course, you don't want to ablate arteries that are very small, less than 3 mm, and also arteries that are quite large because there will be no contact with the catheter if your arteries are more than 8 mm. So this is just a sample representation of the number of catheter ablations that we did on this 52-year-old gentleman. So we did a total of 18 ablations on the right and 19 ablations on the left. So this is following the new protocol. We would use only about 11 ablations or 12 ablations for both kidneys in the past, and we would avoid the branches. But now we really target the branches. So this is a patient, and this patient came back to us. This was done more than a year ago. And this patient came back to us with better controlled 120 over 80, still on the same medications. I'm hesitant to remove some of the medications, but at least we were able to reach our target of less than 130 without adding more medications, which the patient refused to do. The second case that I will share with you is actually a more interesting case. Young female, 41 years old, came in for cerebrovascular bleed. Okay, she was diagnosed to have hypertension for some unrecalled duration and was not compliant with medications. She was referred to us because of resistant hypertension on 8 medications: calcium channel blockers, ARBs, beta blockers, hydrochlorothiazide, aldactone, an MRA, and a centrally acting medication, clonidine. So this patient, again, usual protocol is to do selective renal angiogram after doing the aortogram, and we found out that she had only 2 renal arteries, which is normal for most people, so no accessory renal arteries. And this is our representatives pictures or images of how we did renal denervation. This patient had a total of 27 ablations. She's a petite patient, young female. And I'm happy to report to you that this second case that I'm presenting to you, almost immediately the day after, which is unusual, but almost immediately the day after, her blood pressure was better controlled. Actually, we had to hold up some of her medications, but over several days, then her blood pressure started to go up just a little bit. She's currently only on 2 medications for blood pressure after more than a year. Very well controlled BP from more than like 8 medications in the past that could not control the blood pressure. Now she's down to 2 medications with very good BP control. Let me just share with you one other case, and this is a case of someone who has multiple renal arteries. Again, he has an accessory renal artery on the left. 42-year-old gentleman, hypertensive for 8 years, usual blood pressure 140 to 150 over 90. He was previously diagnosed to have heart failure due to myocarditis. He has obstructive sleep apnea, however, not so compliant with CPAP medications. He was on 3 medications: calcium channel blocker, beta blocker, and an ARB, but refuses again to take more medications because he was anxious that he would have adverse reactions. So we did several selective angiograms on the right renal artery and on the 2 renal arteries on the left. These are representative images of the catheter ablation on the right renal artery and on the left renal arteries as well. This gentleman had a total of like 63 ablations. Again, much more compared to the usual 12 ablations that we used to do way back in 2013. And this patient's blood pressure, apparently, this is like more than 6 months, if I remember correctly. His current blood pressure is like 120/80, or sometimes even lower than that. Still on the same medications because we want to target less than 130, but at least we did not have to add more medications. So who are the potential candidates for renal denervation? First of all, those who are not controlled despite drug therapy, and this will include resistant hypertension. But for those of you who would consider resistant hypertension as something like 180/120, no, that is not resistant hypertension. Resistant hypertension is hypertension that you cannot control using 3 drugs, or actually blood pressure that is controlled using 4 drugs that's actually classified as resistant hypertension. So blood pressure of 150/90 that you cannot control, these are patients who are potential candidates for renal denervation. The next group of patients who are candidates for renal denervation are those who cannot tolerate drugs. You want to add more drugs, you are not using maximum number of drugs, but these patients cannot tolerate the drugs anymore. So again, these are patients who are potential candidates for renal denervation. And the third one, because it is very important, it is as well emphasized in the American and European recommendations, that patient preference should actually be taken into consideration. So the physician should always discuss with the patient that lifestyle is very important, medication adherence is very important, but they should also realize that there are other options, and this may be a third option for controlling blood pressure, and this is renal denervation. Again, in 2013, St. Luke's performed the Philippines' first successful renal denervation. We were very happy. We took a picture, put it on social media and on print media. However, because of the quote-unquote negative results of the Simplicity HTN-3 trial, the program was put on hold in 2014. However, with the results of the off-med, on-med, Global Simplicity Registry reports, we are now back in doing renal denervation, and we started doing renal denervation again in St. Luke's Medical Center starting 2021, so more than a year ago. So with this, I would like to thank you for your kind attention, and I would be very happy to answer and discuss with you any queries or comments that you may want to raise. Thank you very much.
Thank you po, Dr. Cruz, for that very comprehensive discussion on another treatment option for our treatment-resistant hypertension. So the floor is now open for any questions from our viewers. So we have one po, sir. So ang question po is, how much po ang RDN sa St. Luke's?
That's usually the question that we get. That's usually the last question that we get. Di ba? Normally, they would say, is it effective? What are the adverse reactions? Does this mean the patient should not take medications anymore? So this is an awkward situation where I am asked how much it would cost, because the procedure is quite costly. The catheter alone is probably in the area of about 350,000 pesos. Okay, and so plus hospitalization, the patient has to be put on sedation. The hospitalization, by the way, is just overnight. So it probably is in the area of about 500 to 600,000 pesos. And I think the Philippine Heart Center, the center already has done quite a few at the Philippine Heart Center. Cardinal Santos, I think, has done one already, and St. Luke's Heart Center and Cardinal, they have about the same cost, which is quite costly. I must admit, it's about 600,000 pesos for the entire procedure.
Okay, sir. And then follow-up question is it possible to discontinue all the antihypertensive medications?
Okay, this is a more relevant question, I think, and this is where managed expectations come into play. You should not, this will not replace lifestyle change. Okay, you still have to instruct your patients to avoid salt, to minimize salt intake, to have regular physical exercise, to try to lose weight if they're overweight, because all of these can lower down blood pressure effectively. Effective lifestyle change works. Okay, medications should still be continued because we have enough evidence that taking medications lowered down adverse effects also, or long-term cardiovascular outcomes. Long-term medication, long-term cardiovascular outcomes can be lowered down by taking medications. Now, there are patients who don't want to take more medications because it is affecting the quality of their life. Okay, and this is when patient preference may come in. But this is very important that we explain this very well to the patient. Lifestyle change should continue, medications work, but if you don't want to add more medications, and if you are already on maximum tolerable medications, then renal denervation is the next option. So it is not a replacement for these two, it is an additive. And in some situations, you may actually lower down the number of medications. In that example that I told you earlier, the second case, from 8 medications down to 2 medications. So it is possible, but you need to tell your patients that, this is not a replacement. Number two, it does not work right away. It takes time. So the first month, maybe you will have only like 5 millimeter reduction in your blood pressure. Maybe after a year, it's a 10 millimeter reduction. Maybe after 2 years, it's 20 millimeter reduction. And maybe, hopefully, eventually, you may have less medications, or at least you don't add more medications, or best possible scenario, no more medications. But your patients have to realize that this does not happen like magic.
Okay, sir. That's very clear naman po. Talagang adjunct lang siya, sir.
Yes.
Aside from the lifestyle change. Sige po, sir. I have a question po, sir. So I've read po kasi yung sa Simplicity 3 po na trial na they excluded po yung patients with isolated systolic hypertension.
Yes.
So currently po ba, ganun pa rin po ba yung natin?
Not anymore. Not anymore. Kasi before, what they wanted to show was that this was a treatment for resistant hypertension. So the subjects that they included were only those with resistant hypertension. However, it was quite frustrating because there was not much difference between sham and the placebo and the actual renal denervation. But what was very well established was safety. Now, when they redesigned the protocols with off-med and on-med, and of course, in the global registry trial, it was not limited to isolated hypertension. It was not limited to resistant anymore. So isolated systolic blood pressure was included, especially in the global registry where it's a real-world experience.
Okay po, sir. And then, is it recommended for those with CKD already to undergo such invasive procedure po, sir?
Okay, in the trials, they were not included. In the registries, it was actually discouraged because they were not included in the trials, in the randomized trials. But there are a few studies, particularly in Italy, where they actually did renal denervation on patients who already have CKD. In the global registry, there was no deterioration in the RDN group. The deterioration was actually the same as the normal deterioration of kidney function in hypertensive patients. So there was no added deterioration due to the procedure. In the randomized trials, there was no difference between sham and placebo and the actual RDN. What is fantastic about this case is that the safety actually, even among CAD patients, is high. But at the current time, it is not part of the recommendation. Although you may argue probably that the patients, particularly those who are undergoing hemodialysis, that their blood pressure is very, very difficult to control. And this may be one population of patients who may benefit from renal denervation. Again, no big studies, but at least I know of one study in Verona, Italy, where they did renal denervation on hemodialysis patients who have poor blood pressure control, and it worked. And of course, there's nothing to destroy. No more deterioration in kidney function because these patients were already end-stage renal disease
Okay
patients.
po, sir. And then, I've read din po kasi, sir, yung incidence po ng renal stenosis po, sir.
Yeah.
In your clinical practice po, sir, did you have any experience on this complication?
None. Fortunately, none at the heart center. There's none. Also, Cardinal Santos, there's none. Locally, there's none. And the incidence is actually 0.7. It's not even 1%. No. So I don't know if that will really translate to anything that may make this procedure not acceptable. And that renal artery stenosis did not translate to any significant what you call cardiovascular or anything that led to the patient's death. No. So it was just an incidental finding that there was a 0.7% incidence of renal artery stenosis. It's not surprising because you introduce heat. You actually ablate the renal artery, and that's the reason why we are now very, very careful. We don't want to ablate in the ostium or the very proximal part of the renal artery, and we just focus our targets on the distal branches.
Okay, sir. Clear po. And then, sir, tawag dito.
Mukhang nagbasa ka talaga, ha?
Yes,
Okay.
sir. Pinaganda
Aaron,
ko, sir.
that's good.
Interesting po yung topic eh. So yun po, sir, for renal denervation, do you have any dynamic parameters to monitor after the procedure aside from the BP monitoring?
We monitor renal function, particularly the EGFR if there is deterioration. And so far, we have not seen any. If ever there is, there might be even a slight improvement, although I don't think this should be attributable to the procedure itself, but probably because of better BP control.
Okay po, sir. So,
pero masakit to, Aaron, ha? Nararamdaman ng pasyente during the procedure. You have to give them extra sedative. Of course, they are not put on general anesthesia. No, we just give actually dormicum IV, which is easier to control, and a little bit of fentanyl. But because whenever we would ablate, and we want to ablate as much as we can, but whenever we would ablate, there's a sound. Merong tuk tuk tuk. There's a sound actually, and not only in a few patients, but a lot of patients would actually anticipate that sound. And when they hear the sound, they will start complaining of pain. Sabi, masakit. Sabi ko, wala pa. Sound pa lang yun. Ha? So parang nagkakaroon sila ng conditioning na when they hear that sound, they would start experiencing pain. The pain is felt at the flanks, because you introduce heat. Now, the machine actually has a self-regulatory mechanism. It will not burn, no? Kasi there is actual flow of blood, so yung blood itself will cool the system. And if the temperature goes too high, it actually stops. There are 4 ablation points. So kung isang point masyadong mataas yung temperature, it actually stops. And then you can just position it somewhere else and then repeat that point only. It's very, very user-friendly. And I've been telling my colleagues in interventional cardiology that this is something that's much, a lot less complicated to do compared to coronary angioplasty.
Okay po, sir. Another question po, sir. For patients na, yun nga po, nag-undergo na po ng renal nerve denervation, is there a chance na, let's say, mag-fail po yung BP control, the patient would also undergo another procedure? Possible po ba yun?
Well, potentially, but I guess that will be technical na lang yan, no? If the first operator probably did not do it quite well, did not ablate as many areas as possible, or in patients who underwent the first denervation, the flex catheter way back in 2013, that was 10 years ago. And now is beginning to have rises in blood pressure again. That may not be a sign of failure. It may actually be a sign that we did not ablate enough. Okay, so it's possible to redo it, but with a new catheter, there is actually no need to redo it. The other question probably some people may be wondering or maybe asking is that will these nerves regenerate? Di ba? Kasi there's a tendency for our human body to heal itself. But these are non-myelinated nerves. So once you burn them with radio frequency, they don't regenerate. So the effect is what we call durable. It lasts.
Okay po, sir. And then my last question na, sir. Baka naman
No,
sabihin ng iba.
I'm enjoying
Ako
your questions actually. These are very, very valid questions. These are questions actually that are raised during international fora.
Ayun po, sir. For my question po, nawala ako, sir. Ayun po, for my question, kasi po, di ba, tawag dito, for resistant hypertension po siya na patient. So, is it safe to say na it should be part of the best practice for our clinicians to offer to our patients already, early on?
Yeah. If I may share my own experience, kasi I hate doing hard sell. I mean, I do procedures and it may appear like I'm promoting this because I would earn from the procedure. No, but I have realized also that if I am treating a hypertensive patient, of course, we all need to emphasize lifestyle change. And I want the audience again to emphasize lifestyle change. Low sodium diet can lower down your blood pressure by 5 to 10 millimeters. High potassium now, unless you have issues with your kidney function. There are now new studies that if you take adequate or a little higher amount of potassium, that can also lower down your blood pressure. Physical exercise, we all know, can lower down blood pressure. Weight loss, even a 5-kilogram weight loss can actually lead to about 20 millimeter reduction in blood pressure. This works. So emphasize lifestyle. The next thing you need to emphasize is that medications are safe. Okay, although some people may have adverse reactions, but you have to emphasize that medications work, and people who take their medications properly will have less strokes, less heart attacks, less kidney failure in the future. But there are just people who cannot tolerate medications. And it is important at this point, 2023, that we let them know that there is such a thing as renal denervation, because patients now have more access to information. And you may turn out to be a bad clinician if they say, how come my doctor never mentioned that there's an option for renal denervation? So this is not to sell renal denervation to them. This is just to inform them that there is an option, because somehow these patients will find out through other sources, whether from the internet, social media, or from other patients or from other physicians. And you as a hypertension physician may be faulted for not offering this, or for not informing the patient. Not really offer, but for not informing the patient that such an option exists. That's how I look at it.
Okay, sir. Maraming salamat po. Mga patients kasi nowadays, sir, talagang Mr. Google sila lahat eh.
Yeah.
Ayan po. So,
the term dyan, Aaron, Google Chondriac. Okay. Yung mga hypochondriac, meron na sila Google Chondriac patients.
Lahat search na, sir, sa internet.
And they will find out, and they may fault you for not informing them. So it's not to sell the idea to them. This is just to inform them that there is an option. And then most of the guidelines now, they always focus now on patient's preference. You need to discuss this with patient. You need to consider what the patient wants. It's not only what the doctor wants. The patient has to be consulted.
Okay, sir. Thank you, sir. Do we have any more questions from the floor? Naubos ko na ata, sir.
Yun nga, yung usual last question, how much? Okay. Pero yung naging first question natin eh.
Una na po.
Mm.
Sige po. So if there's none, thank you po Dr. Cruz for giving us your precious time. No, very informative po itong naging discussion natin. So may I now call on Miss Nancy to present the certificates. Sir,
Thank you,
thank you
Aaron.
po.
I enjoy your the way you moderated this presentation rather.
Thank you, sir.
Thank you, Doc Aaron and Doc Nick, for the very informative and interesting topic. In behalf of Healthway Philippines Incorporation, I present this Certificate of Appreciation to Doc Aaron Christian Earl I. Villoso for his expertise and valuable role as a moderator during the webinar entitled Renal Denervation, the Next Treatment for Resistant Hypertension, given this first day of February 2023 via Zoom virtual event. It is signed by our course director, Christine Lorena de la Vega Arrienda Mojica, Dr. Gina Nazareth, our head of medical affairs and PSQM, and our president and CEO, Mr. Jaime Ismael. Thank you, Doc Aaron. Another appreciation. In behalf of Healthway Philippines Incorporation, I present this certificate of appreciation to Dr. Jose Nicolas M. Cruz for his expertise and valuable role as resource speaker during the webinar entitled Renal Denervation, the Next Treatment for Resistant Hypertension, given this first day of February 2023 via Zoom virtual event. Signed by our course director, Dr. Christine Lorena de la Vega Arrienda Mojica, signed also by Dr. Gina Nazareth, our head of medical affairs and PSQM, and also with our president and CEO, Mr. Jaime Ismael. I would just like to remind, please don't forget to fill up the evaluation and answer our post test posted in the chat box. This will serve as your attendance. Thank you.
So I think, sir, that concludes our session for tonight. Thank you, sir, for your time po.
Thank you also, Aaron, and thank you, Nancy. Have a good evening.
Thank you,
Evening po.
doctors.